is not where they should be, and we reduced that by more than half within 18 months. So they're quick wins. We can show something another day. We can show the CCG, you've invested this money in this improvement, here's the win. And we can sort of show you all sorts of health economic things and saying, we will prevent this many strokes, and here's the business plan, and so on. But a kind of, so it's a system, not a plug-in. We've got guidelines. We're all using the same templates. We're all using the same data entry right across the piece. They're smart. They give you back information. They've got hyperlinks on them, and so on and so forth. And I can show you. They facilitated. We've got workshops. There are various tools that you can plug in. There are searches and there are dashboards. So we've gone from 2008 to the bottom quintile up to the top in 4 years. I don't know how much more time I've got. A little bit more time. Okay, right. I'll just talk about a couple of other things. So we've got also developed a kidney service, which is kind of relevant around cardiovascular disease. It's and just to show you that we've got the highest rates of hemodialysis, or some of them in England. That's you can see that Newham is particularly high. There's England down the bottom, our 3 CCGs. So what are we going to do about that? We have set up a CKD e-clinic, which is where we can put in referrals, and the consultants in the hospital can see our records. So we've got a sharing agreement. So with the patient's permission, they can look at the summary of or they can look at the actual EMIS record and go through it. And we've got a set of tools that are now being run out across the practices. They put it in. It's a little tool. You plug it into your system, and it shows you anybody who's got an EGFR below a certain level, and then if it's fallen a certain amount, it'll flag that patient up. You review that patient, and you say, oh, I can see this person is dying. I don't need to do anything. Or you say, oh my gosh, I knew that person's renal function wasn't very good. It's declined much further. I'll refer them into the virtual clinic and see what the renal physicians have to say about this, and they may say, it's fine, sort of ease off on the diuretics or do something. I don't need to see this person. They may say, I really need to see this person in my clinic, and then they'll actually see them. But they've sort of slashed waiting time. So this is just a set of EMIS screenshots about how that happens. But that's an example of somebody's declining renal function. And at this point, they went into renal failure and went into hospital. But you can see that if we identified that fall, sometime earlier, we might have prevented that kind of thing happening. So we're beginning to use these systems to, in near real time, do surveillance of whole systems for adverse events, and whether those adverse events are prescribing non-steroidal inflammatory drugs, or whether they're looking at adverse renal outcomes, or whatever. You can begin to get this very important intelligence back from your systems in a clinically meaningful way. I think that's the kind of key phrase here, what's clinically meaningful. So what have they done? They've slashed waiting times for consultant advice. They're managing about 70% of referrals without the need for hospital attendance and so on. So it's an interesting system. We'll see whether it makes any difference to hemodialysis rates. Too early to tell how it will work out. So I was going to go on. So just one last thing, which is where we're going next, and that's with this program, with Discovery. And some of you, well, you can't really see it there, but that's the John Snow map of, not quite East London, it's Soho, where he chained the pump when they had an outbreak. And that's the digitized map of that same outbreak. And it's, again, about how we use our information to work smarter. And at the moment, we want to change this situation where, in East London we go all our primary care records in EMIS, all the hospital records in Cerner, over there social services, and over there is what's now called digital health. We won't give you anything for love nor money. And so how can we, kind of join this up, not just in some kind of administrative data set like HES, which is a billing system, it's not fit for clinical purpose, but for something which is fit for clinical purpose in near real time. So that's where we are going with our Discovery program, and we've got a guy called David Stables, who was one of the founder members of EMIS, to help us with his charity called Endeavour Health, to put into a system which will bring together both the hospital and the primary care data into a single integrated service. We've already got views of these systems. I can get a view of the hospital data, a static view like a PDF. It tells me not a lot because they don't use computers very much in my hospital. I can see the next outpatient appointment. I can see images now, which is very important. I can see CT scans, and we'll get more views of that. So it's very important to have these views, and they can see our record with a summary in this view of the medication, the problem list, and so on. So that's really important. But those are static views. That's not a data service. A data service means you can integrate fully the data and join up other systems, and that's where we're going with that. So it'll give us near real-time reporting. We'll be able to relate outcomes to process such as, bleeding and the use of anticoagulants, hip replacement failure, all these things that have a kind of an outcome which is often in the hospital, we'll begin to look at and so on. So, and hopefully duplicate testing, look at predictive scores, decision support, research, and so on and so forth. So that's kind of where we're going, and this is kind of the kind of look of this beast. Down the bottom there, we've got all the systems that we've got the EMIS system, we've got an out-of-hours system, we've got a community system. We're going to want to bring all that into a data service, and then we'll have various people that can plug into that. The data controllers can plug into it, the providers or public health and so on, and researchers with appropriate governance. So I think that's kind of the future. And so that would give you kind of a much richer data set. And it will tell you, things like the workflow, who am I consulting, discharge dates, summaries, care plans, patient system flows. It'll give you this visualization review, so the possibility of plugging in patient apps, dashboards, virtual clinics. Improvement, efficient pathways, where are the delays in the system, medicines optimization, stroke reduction, monitoring EGFR, a whole set of things, and then there's research and safety. So I think that's where we want to get to, and it'll give us a kind of new type of view. But I think for the time being, we've got our good old primary care systems, and it's about kind of saying, well, how can we make better use of that? But at the end of the day, it's not the IT, it's an enabler. You come back to that group of people around the table about discussing what it is that we're going to do next, what's your priority, be careful that you choose something you can win on. Because the tendency is to say, what's the most difficult problem? I want to solve A&E attendance. You think, my God, this is not where I want to sort of begin. I want to begin on something I know I can do. I can reduce the blood pressure, I can reduce cholesterol, I can improve anticoagulation. I think that's kind of my main message really is choose wisely, which is the American campaign, but they're quite right about that. But I think we can do it even better than they can. So I'm going to stop there. Thanks very much.
So, we have
10 minutes for questions.
It's all on there, sorry, that was us. Obviously, you have the technical issues, so they didn't want to mess around with their computers. Because otherwise, they would have had presented you, we would have had full screen.
Do we have any questions?
Do you want to shout? If you shout, I can repeat your question. Yeah.
Yeah. We'll need to have the question repeated, I think.
He's going to repeat it, I think.
Okay.
So, obviously, is it the actual system, or is it the sitting around and actually having the capacity? Because obviously, 1,000 TVs, action all the time.
No, that's right.
The ratio to patients is massively different.
Yeah. So what the question was, do you have any, what extra resources have you got that you've done to achieve this? That figure of 1,000 is everybody, so it's not full-time equivalents, it's just all the locums and it's just giving you a rough idea of the kind of the numbers that we've got. No more GPs, I don't think, than we have anybody else. We don't have any more in our area, so it's not a GP workforce issue at all. And we have all the same kind of recruitment problems as anybody else. I was talking to a guy in Bradford who's also done, on Bolton, who's done very well. He said he hadn't had a single applicant for their vacancies in the last sort of 6 months or something. So no, we don't have any more resources. What we do have is some investment by the CCGs into the organisation to produce the data and support these programs. And as I say, it has these three components. It's got some critical leadership, a little bit. It's got a data analyst, and it's got a facilitator. And that kind of, we put together sort of 4 CCGs. So we've got about a dozen staff now then working together, because many of the issues, if I'm building a data entry template in Newham or a dashboard, then it can be applied to, the other CCGs. So it's scalable, I think that's the point. And so getting together a critical mass, I'm just talking to some people in Southwark, and they're just going to do the same type of thing. They've got a bit of funding for their CCG. They made a business case. They've got a clinical lead who's quite passionate. They've got a data analyst. They all have to be EMIS there, so they can extract the data. But it could have been System 1 or it could have been Vision. And then they can begin to feed that back in a meaningful way. So I think so there was a resource, and that was important. I think it's more, and we got that resource initially when it was in a more resource-rich days of Gordon Brown and so on. But they've continued to invest. So we've survived, changes of government, changes of organisation in 2013, and so on, because they can see the value of it. And we run about, not just CBD, but we're running about 50 programs in each of the CCGs now, so ranging from sexual health to COPD, to diabetes, to CVD, and each of these programs has a set of metrics, targets, and payment sort of elements to that. But I agree with you, though, with the resource. When I go to somewhere like Enfield, which doesn't have any of this, they've just got standalone computers. They don't connect them in any way at all. It's like going back 30 years to me. And they don't quite get what I'm talking about either in the CCG. So I think it is having a conversation and saying, well, how can you perhaps build on something that you're already doing to further extend it and improve it? It's quite difficult to sort of, entirely build something from scratch. So most people are interested in diabetes or some anticoagulation. So we've used that as a sort of can opener to try and get to some of these other CCGs and says, well, why didn't you start using data to feed back on pulse checks or atrial fibrillation or whatever? And then once they see that the model works, you've got a quick win, you can say, well, why don't you make a further investment in this? To support it for a wider range of topics, but it's beginning that conversation is often quite hard, particularly at the moment when nobody's got any money. I agree.
We got any more questions?
Hi, Jonathan Richards. In Bolton, I think it is, they did use some form of incentivisation, yes. And I can't remember, I think it was called logarithmic incentivisation. Yes. And I seem to recall from your British Journal of General Practice paper that when you were looking at cardiovascular disease risk reduction, you also used some form of QOF-related incentivisation or additional financial support to practices. Given that you're now doing so many different things, do you still have some form of financial incentivisation, or are the doctors and nurses doing it because it just helps them to be better doctors and nurses?
No, they very clearly say that if we're doing extra work, we want extra resources and extra money to support that. And I think that's very important, and I think we should demand that, really. Nobody's going to do anything for nothing or extra in the present context. There is no spare capacity. We're at the sort of end of everybody's tether, really. So I think there has to be some financial incentive that will kind of assist the motivation. It doesn't have to be very much. That pulse checks was done on very little money, indeed. And or individually, there's not a lot of money, but it's some money, and I think that's an important thing. I don't think it's the amount of money necessarily; it's the recognition that your work is in some way being rewarded with some degree of resource. And what the CCGs have done is actually moved. They've got the same amount of money, but they've moved it around. So we're now having a discussion about moving off QOF, but moving the same amount of money to other metrics. So, for instance, we've got the COF has this 150/90 blood pressure target. We said, well, why 150/90? All nice guidance says 140/90. We know that we'll get more bangs for our bucks if we have this extra 10 millimetres of a reduction. Every 10 millimetres of a reduction is about, 15% reduction in stroke. It's massive. So, let's go for 140, incentivize that target rather than the CROF one. So they just moved the CROF money onto, that target. So it's the same amount of money, as it were, but we're moving it around so that once you've got kind of it embedded in a culture, perhaps like the pulse checks, then, perhaps people might be more, once they've all got up to 90%, they're kind of doing it and the whole system is rolling, you can move that incentive onto something else and say, well, maybe we can shift it there. But I think there does need to be some degree of money in it, yeah.
Well, unfortunately, we're now out of time, but thanks ever so much, Dr. Robson. That was really interesting. And there's also some workshops run by Dr. Robson this afternoon with Welsh GP Alan Edwards, and I'm sure he'll be happy to take questions if you nab him while he's wandering around into the conference. So now we're going to get a Welsh perspective, and I'd like to introduce you to Dr. Jane Fenton-May, who's Vice Chair of the Welsh College of General Practitioners. Thank you, Dr. May.
Thank you. Well, I'm actually not a practicing GP. I have to admit that because some of you know that already. As I was telling one of my classmates that's in the audience, at one stage I knew a lot about the heart because I went to Professor Henderson's lecture in Cardiff University as a student, and he told me the one thing I ever remembered was the heart was a pump. I remember that for a long time. I found a lot of the other things very difficult to remember, but I did do a lot of work with muscular dystrophy patients for about 20 years as a part-time job, and I did learn it was a little bit more complex because I learned a lot about cardiomyopathy and I learned a lot about arrhythmia in the context of those patients. But in order to put together this talk, I did talk to some of my colleagues. So some of these comments that I'm making now are to do with what I've come up with from there. And I think that our last speaker is very lucky because he seems to be getting things brought together in his LHBs. But I think I've missed out a slide. There we are. But I think one of our great problems in Wales is we've got these small units, we've got lots of LHBs, the access to the services in the LHBs is very varied, and you, as a network, have an opportunity potentially to standardise some of these things and ensure that we're getting the same services for all of our patients, whether they're rural, they're in a different area from the hospital and the LHB and all these divisions that we see. So some of the things that I was particularly asked to point out was that, because I presume that you have a complex audience of hospital and GP people here, was that we need to ensure that discharge letters, both from outpatients and inpatients, are improved and easy to understand for the GPs. There needs to be actions for the GPs that are very bold and easy to understand. The letters need to get to the GP at the same time as or before the patient comes, demanding all the different changes in their medication or has got queries about things. We need to ensure that we know when it's a suitable time to send our patients back to the secondary care for a review. What sort of symptoms, what sort of concerns should we be highlighting with them that they need to come back and tell us about? So the other thing is drug changes. And I think that in some areas, I believe in Swansea, you have got a very nice system whereby the drugs are highlighted when they are changed so that people know that these are a new drug and not the old drugs. But that doesn't happen in all areas. That you need to make sure when patients go up to secondary care that actually what is in the last letter in the outpatient notes is actually what the patient is taking or thinks they're taking, because that's not always the case. You need to make sure also, if you're looking at the individual patient record and the drugs on it, that that includes any hospital prescribed drugs, because they aren't always, there are mechanisms you can try and put them in there, but the current mechanisms are not very easy. Shared care protocols, they're the nightmare. Some of the junior doctors don't realise that some medications are on shared care, so they write a letter and say, oh, please start this patient on X, Y, and Z, and it's a shared care protocol. The patient should be monitored, stabilised by the secondary care, and then the doctor, the GP, has to consent to take on the shared care protocol patient, and some of the GPs do not feel that they have time capacity or the knowledge in order to manage those patients for whatever reason. And the other thing is there are local formularies developing. So why, when my patient goes to hospital, does the consultant or the junior doctor decide to use some bizarre other drug which isn't part of the agreed formulary for the area? And if there may be some special reason for that, but they don't specify why they're going outside of the protocol. I'm happy to go along with what the consultant says, but I need a reason to justify it, so when somebody says your costs are very high in general practice, that I can justify why I'm using things outside the formulary. Nurse-run clinics, these are wonderful, but, and they're very varied in different areas, I'm sure, but in some areas, the letters, again, are very slow coming. So the patient rocks up in the clinic saying, I need X, Y, and Z drug, because the nurse running the clinic isn't a prescriber and has advised the patient that they need to get new drugs. So that you have to wait until you get those letters. And so that's a waste of the patient's time, a waste of the GP's time. Blood results. In some areas, the nurse-led clinics are using community forms as opposed to hospital forms, and this may be a local area problem. And so the results go to the GP, who hasn't initiated the test, doesn't know what's supposed to be monitoring, what action to take as a result of the test. I mean, yes, they may make a guess, but they haven't actually specifically asked for the test, so they don't know what the person that was initiating the test wanted to get out of that. Waiting lists for hospital cardiac procedures. Patients are terrified when they're on those waiting lists. We need to help support them and reassure them. And the patients need to be, and the GPs, need to be given explicit information about what to be concerned about and when they need to be readmitted and when they need to be reviewed. When should the drugs be modified, particularly in failure patients? And what sort of activity can they do while they're waiting for their procedure? Because actually we want our patients to be active. We don't want them to be stuck to the chair saying, oh, I've got some horrible heart thing and I better not move in case it causes problems. So, in fact, a lot of these things are embedded in some work that I have done for the Academy of Royal Colleges in Wales. There's been similar work being done by the Academy in England. And these are and this work was requested by the acting CMO for Wales, who was a cardiologist, Chris Jones, and he asked the Academy to look at the behaviours and the communications of doctors specifically, because he felt that, you know, there are problems across the NHS, but we need to start with the doctors and change the culture. And these were the core principles that we came up with as a result of this work that we did for the Academy in Wales. And they are on the Academy website, and you can have a look at them, and they're more explicit in there. But actually, they're all the things that when I asked my colleagues about what the problems were with cardiology, they came up with. So the other specific things, electrocardiograms. Now, some places you have direct access from general practice, some you don't. Some of them have very long waiting lists. I don't know the answer to this. Is the variation across services due to the fact that people are asking for too many, too expensive, or the lack of scanners or people that can work them? I don't know. And I used to find that when I was working in genetics with my patients with muscular dystrophy, instant echo, and I'd get it reasonably quickly back. But as a GP, even on the same patient potentially, I wasn't allowed to request it. Now, that may have changed over the years, I don't know. The other heart-sick thing is, for GPs, is paroxysmal AF. And maybe we're going to get the answer with the next lecture, I don't know. But we do need some clarification about, you know, when do we treat, when do we not treat, how far do we go with managing these patients? And that's probably from the consultants. My final bit, which is, again, some work that I'm doing with the Academy of Royal Colleges, is thinking about life-limiting conditions. And we all know we have patients who have cardiac problems, who have life-limiting conditions. And we as GPs write a letter to the cardiologist and say, Mrs. Jones has deteriorated. I don't know whether there is anything else that she can do, that can be done to help her, make her feel a little bit better. And so the patient eventually sees the cardiologist or the other secondary care doctor then puts this patient into a spiral of lots and lots of different tests, different regimes of treatment, and actually probably the answer that should have come before they went down this road was a discussion with the patient that actually, I think you've got cardiac failure. I don't think we can make you an awful lot better by doing any of these things. And what we need to do is make you comfortable, make the last part of your life as comfortable as possible, and put your life in order. Now, we all know, because there was a study recently published and got lots of publicity about the surprise question, which, if you're involved in palliative care, the surprise question is, you say, would this patient be alive in 6 months or a year? And if the surprise answer is that they won't, then you start putting them into some sort of palliative care procedures. Now, the study got a lot of bad press because it said that the surprise question was wrong in a lot of cases. But what it had highlighted was most of those patients still needed to get the support and care for palliative care rather than just being left to cope with their illness in that last phases of the illness. And from my work with muscular dystrophy, I know your last phase of your illness is very varied and it may be several years, but you need to start making those preparations so that you know that, you know, you're not going to get better, and you need the support to learn how to live with the fact that you're going to die. And a lot of our severely cardiac disabled patients need that support. And a lot of the cardiac nurses are really good at doing that, so I'm not knocking it, but we do need to ensure that we as doctors, both in secondary and primary care, are having that dialogue with patients and ensuring that we communicate with them and enable them to do that. So, right, there may be questions that the cardiologists want to ask us as GPs, and I think we've got actually quite some good answers from the last speaker about how we can improve care. It is interesting that they've managed to do this in an area where the number of patients is about a third of the size of Wales, even though they seem to have quite a lot more doctors in that third of the size of the Wales. But even bums on seats doctors, I think we've got about that for the whole of Wales, but I need to check my figures. So thank you. Are there any questions of me? And just to remind you, this is the information from the Academy that we're trying to get out there to change cultures. These are the core principles that help communicate across the primary secondary care interface. And why is this important? Because that's where most of the significant events and critical incidents occur in medicine, at that interface, with medication being highest amongst those. Thank you very much.
A roving mic, have we got any questions? So the speakers are really doing very well, I have to say. Very impressed. Have we got any questions in North Wales? Can't see.
North Wales, we have some independent prescribers and specialist nurses who don't prescribe but advise GPs. The common place for conflict. No questions here, though.
That's great. Thanks, Graham. Well, I guess we're ahead of time then, and we can move on to our next speaker. I may have surprised him. Here he is. So, I'd like to introduce you to Dr. James Barry, lead clinician from Mid and West Wales and Wales Cardiac Network, who's going to talk to us about what our patients deserve in the treatment of AF.
Good morning. Thank you for inviting me. One declaration, I'm not a GP. I'm a cardiologist. I am still seeing patients. My specific day job is I'm an electrophysiologist in the tertiary centre up in Morriston, where I deal with arrhythmias. So I've been asked to talk about AF and what our patients deserve, which is a slightly more clinical topic, I think, than the previous two talks, although it fits in as this is a point where I think we have a chance to consider how this condition might move into the community, and before you all rush the stage with sharp objects, I do think you'll need more resource to do that. I think this is a community-based condition, and we need to start working about how we can deal with this in a more modern healthcare setting with less interfaces and more fluid boundaries, or less boundaries, more fluid patient movement. So that's me and my declaration of interests. And this is a quick overview. So we're just going to talk a bit about why AF matters, how we diagnose it, the treatment, and then perhaps we'll have a discussion about how we can then work together to manage it in the future. This will not be on to NOACs, you'll be glad to hear, and similarly, but I'm afraid there will be ECGs in the talk. There won't be any audience participation during the ECGs, though. Okay. So AF is the commonest arrhythmia. 1 in 200 people have it. So if we've got 200 people here, one person has it. The incidence doubles every 10 years of life, such that at 75 and above, 1 in 12 people will have it. So that's the incidence here, with age here in decades. I'm just about here, so it's increasingly becoming a subject of interest to me. But we do see a rapid rise in prevalences and incidence as people get older, and we're getting an aging population, so we're going to see an awful lot of it. What is it? It's an irregular heartbeat, obviously. Because of that, your atria no longer contracts in an organized way, so you no longer have efficient filling of the ventricle, so you lose about 30% of your cardiac efficiency. It's a common bedfellow with hypertension, ischemic heart disease, sleep disordered breathing, and old age. And of course, you've all seen many of those every day in your clinic. And it's a community-based condition. These people are at home with AF. The vast majority of people don't even know they're in AF because their expectations aren't very high, and therefore they don't expose their limitations. But most people with AF are walking around in AF, not really aware of it or not too bothered by it, but are still running a risk. And then there are, of course, the people who then present to you because they are bothered by it, And these are people who will present to you with palpitations, breathlessness, fatigue, and anxiety. You know, if your heart starts clattering away at 120 beats per minute in a syncopated manner, you're quite unsure what's going on. It does cause a lot of concern, especially when you then go onto the internet and find out that you're likely to have a stroke. It does increase your risk of stroke fivefold. 20% of all embolic strokes are related to atrial fibrillation. That's a lot. And it's a lot of healthcare consummation as well, consumption of a lot of healthcare. Stroke risks can be ameliorated by oral anticoagulation. We've known this for many years. We knew about this long before industry became interested with rivaroxaban, dabigatran, and apixaban. And we know that warfarin does this as well, pretty much broadly, as the other agents, but probably does expose you to slightly increased risk of bleeding, particularly intracerebral bleeding. And these are some of the old trials from the early 1990s, where you can see warfarins in orange, placebos in blue, and black is aspirin. Aspirin has no role in preventing stroke in atrial fibrillation. And you can see that clearly warfarin reduces your risk, and it reduces it by about 2/3 or 70%. This one here run in Canada took all patients, including those we wouldn't consider high risk for strokes. There were a lot of young patients in this study. So how do you diagnose it? Well, it's an irregular QRS complex on your ECG. There's an absence of P waves. There's a fibrillating baseline, and it has to last more than 30 seconds. So those who've had 24-hour tapes that come back to you, and you see a little run of 8-10 beats of something a bit fast and a bit strange looking, with you know, a bit of a wobbly baseline, that's atrial ectopy or a run of atrial tachycardia or multifocal atrial ectopics. It's not AF. You have to have it for at least 30 seconds. It's a line in the sand. There's very little justification for calling it at 30 seconds, but that's what we as a community have decided to say, and that's the point where we start saying this person has AF, and we start considering to be at risk because of that. How much AF do you need to be truly at risk? No one really knows. The assumption has always been that the more AF you're in, the more risk you have, but that doesn't seem to hold true. Certainly when we looked at trying to prove that rhythm control strategies were a fantastic thing to do, first with drugs and then with ablation therapy, as opposed to just controlling your heart rate with rate control, we showed that actually people were having as many strokes in the paroxysmal arm as those who were in persistent AF, and indeed they were coming to harm because we were more diletant with our anticoagulation strategy. So once we got someone back into sinus rhythm, we would stop their anticoagulation, and they were the people having strokes. And that was from about 15 years ago now, the AFFIRM and PF studies. And because of that now, we now consider the risk to be the same whether you have paroxysmal or persistent atrial fibrillation. Similarly, because a lot of patients are walking around with pacemakers now and have a lot of diagnostics available to us, we're able to see when people are in and out of AF. And interestingly, the timeline between someone having a stroke and when they last had an episode of atrial fibrillation does not correlate very well at all. So people often have a stroke several days, weeks distant from their last episode of AF on their pacemaker. In part, that's probably due to electromechanical dissociation and sort of a recovery and milking out of clot from the appendage. But the clear causation link between AF and stroke is far from proven. Certainly the time correlation isn't very good. And you do need to document AF on an ECG trace of some form, be it a Holter or be it a 12-lead, because you are going to be taking decisions that have significant impact for these patients in terms of risk, but in terms of also health care attendances. So catching AF can be tricky. Not every irregular pulse is AF, and AF with a fast rate can feel quite regular, although it feel quite strange because it's going fast. An ECG documenting AF is mandatory because if you're going to anticoagulate someone, you need to be able to turn back through their notes, and so this is why I put them on warfarin when they come in having had their bleed. An ECG with sinus rhythm does not exclude atrial fibrillation. Paroxysmal AF is AF that comes and goes of its own accord. As I've just said, it has the same risk as persistent and permanent atrial fibrillation in terms of stroke. And just because you're in sinus rhythm this day doesn't mean you weren't in atrial fibrillation yesterday, especially if you were complaining of palpitations yesterday but not today. The trouble is patient symptoms don't always correlate very well with rhythm. If you hold to someone who's known to have paroxysmal atrial fibrillation and compare their event diary to their monitor, you'll find a lot of time they feel they're in sinus rhythm when actually they were in AF, and they'll swear blind they were in atrial fibrillation when they were actually in sinus rhythm. So it's very hard to capture all this and actually tie it all together, and more monitoring information is the key. So how do you monitor people? Well, if you've got a 12-lead ECG, you don't need to do anything more. Once you've got it, you've got it. You need to target your monitoring to the time of symptoms and what people are reporting, and you also need to time it to the patient's ability to interact with the technology. They're pretty simple now, event monitors. You just have to press a button, but of course older patients and patients who perhaps haven't grown up with as much technology as we've been privileged to are less able to activate these devices. And I think this is a time where a physiology-led clinic in particular is very useful, because these guys are the experts in monitoring. They're the ones who have to put them on. They're the poor chaps who have to sit in front of the screens of ECGs and just go through page after page after page of monitor looking for any arrhythmias, and they're very good at listening to patients and working out which monitor is best suited for which patient. Increasingly, we're trying to run these sort of clinics to give you an open access to get this done, I would hope. And hopefully this can ultimately move to a physiologist perhaps based in the community who can offer this service. Event capture is helpful, but a lot of paroxysms are asymptomatic. As we said, not every episode of atrial fibrillation, even patients who have symptoms, will be noticed by the patient. So you can have a lot of AF that goes unnoticed. And of course, one period of monitoring in a symptomatic patient just might be the unfortunate fact that they've been asymptomatic or had sinus rhythm for that week, that month, or more usually that 48, 72-hour period when you were looking, and it doesn't mean they haven't had it at other times. You have at least tried to look and shown a duty of care. First ECG, irregular QRS, no clear P waves, and a fibrillating baseline. That's AF. What do these, it doesn't project very well, I'm afraid, but what do these three things have in common? They're all lying. This one says you've got atrial fibrillation, and if you look at the baseline, it does look irregular. It doesn't project well, I'm afraid, but I'll put the arrows up, but there are P waves here, so this is sinus rhythm with atrial ectopics. So it's, it's very easy to say, well, it's AF, just treat it, come on, you just have to do an ECG. It does take a bit of thought, and, it's not always straightforward. And at least once a week, I'll go into one of my colleagues' offices with an ECG, scratching my head, saying, well, what do you think it is? Do you think it is AF? Do you not? And it can be difficult. 99% of the time, it's pretty straightforward, but every now and again, it's not. Patient self-monitoring, presumably with healthcare support, although increasingly they're doing it on their own. This is just a smartphone with something called the Cardia Alive Core app. It's a newer iteration now, so it's even smaller. This was a backplate you actually was molded around your phone. Now it's a small magnetic strip about that size that just sits on the back of your phone. You press an app to turn it on, you hold it between your two fingers, and you get a minute of rhythm strip, which tells you what's going on. And it's very good, it's very high fidelity. You save it, it can be printed off as a PDF, or it can be emailed to you. And I have a lot of patients sending me these, and specifically in follow-up from various ablations. But it is very good, and for those patients who have palpitations which you're never quite sure about, it's a very good way for them to pick this up. We've got quite a few in ABMU, because I did a study recently, which is just, I'll show you in a minute, where we had a lot of them, and we're just trying to work out now how people like Rav and Kirsty, our GPs with specialist interest, might be able to use these to actually help patients at home pick up their symptoms and work out what's going on. The next iteration almost certainly will be completely wearable technology, so you'll always have information about what's going on. So effectively walking around with a continuous monitor, but how you deal with all that information takes a lot of thinking, because, the CIA knew people were planning to attack America in 9/11. They just didn't have enough people to analyze the information. I think if everyone was walking around with one of these, how we would actually pick out the ones who are at risk versus that blizzard of information would be very, very difficult. So we ran the Rehearse AF study, which basically was a randomized trial where we took 1,000 patients and got them to download from one of those live core apps twice a week for a minute, and sends it into us via the internet. If they didn't have internet access, they just had to walk into their local Starbucks and it would do it for them. These patients are high-risk phenotype for stroke, so they're over 65 and one other additional risk factor. And what we showed by doing this compared to the 500 in normal care, we had a 4-fold increase in people who were picked up to have AF in that year. That's just been published in Circulation this month, and if you want to see more about it, there's a YouTube video from the ESC News web blogs. So what we're now doing is saying not only are we trying to find out people who are coming to you with palpitations, breathlessness, and anxiety and finding out that they've got AF, we're saying that in addition to these people who come and knock on the door and we know about, we're more worried also about all these people under here who are having AF, who do have a risk of stroke, and who, because they haven't been diagnosed, are presenting to our emergency department with a stroke because they haven't had the chance of that 70% amelioration in their risk. So we've taken it another step further now. Of course, patients don't come to you and knock on the door and say, I've got high blood pressure, doc, what are you going to do about it? We do screen them, we do treat them, we do reduce their risk. And I think increasingly we're going to have to be thinking about this in the future. And I think this newer technology will break that barrier to this that's previously been available, but actually the reading of the ECGs, the diagnosis that has always held up any attempts in QIPs to try and show that screening for AF works. So management, there are essentially 2 streams to this. And I'm going to make an assertion at the end of this that this part of the management probably ought to be done early, probably ought to be resourced in the community, and probably ought to happen there. And then we'll talk about symptoms afterwards. But this is by far and away the more important part of it, preventing strokes. You should, I hope, have all heard of CHADS2-VASc by now. It's a system that was developed by Greg Yip in Birmingham, where he basically took a cohort of patients and used demographic information that was available on the GP screens to actually be able to decide what someone's risk was. It didn't need tests, it didn't need echocardiography, it didn't need Holters, it needed a diagnosis of AF and an ability to pull this information off your databases. So has the patient been given a diagnosis of heart failure? That's a clinical diagnosis. Are they breathless? Do they have rails in their chest? Have they got raised JP? Has someone said this person has heart failure? Do they have a diagnosis of hypertension? Are they over 75? Are they diabetic? Have they had a previous stroke? Have they got vascular disease, claudication or angina, previous infarct, 65, and whether a woman or a chap? So this is stuff that we can get off our computers quite easily, and it's something we can do quite quickly. What it tells you is their risk of stroke. Now, this was his first bit of work, so the curve is very smooth because it was only over about 150 patients, but nevertheless, it does show you that as you increase these risk factors, your risk of stroke increases quite dramatically. And if you now look at population data using this from Scandinavia and things, this curve is reproduced on much bigger data sets. So we know that once you get to this point here, your risk is about 1.8 to 2% a year of a stroke. Not huge, but a 1 in 50 chance, which you can reduce by 2/3 by putting someone on oral anticoagulation. That's number 2. Do worry about bleeding. NOACs aren't without risks. I would argue that they're no more risky than prednisolone or anything in terms of complications and things that go wrong. But Greg also developed a system to help you work out who's at risk of bleeding and come to harm on these systems, and that's the HAS-BLED score. And again, it's the same thing. I've written hypertension. I should really write hypertensive because this is quite nice. Otherwise, you get 1 for the risk, but 1 for bleeding as well. Now, what this actually says is you can have a diagnosis of hypertension, but if you're now well controlled, so 150 on 90 we just heard, or 140 on 90 we'd all hope, then actually you don't get a score for that. So if you've got treated, well-controlled hypertension, you don't get a score. And that's something you can do to try to ameliorate someone's risk when you're starting anticoagulation. Abnormal renal liver function, previous stroke, bleeding, not surprising. Label INR, well, clearly you're not going to know about that before you started. Indeed, you may never know about it now as we move into the brave new world. Being elderly, again, over 65, and drug or alcohol dependence. So if you then have a HAS-BLED score of 3 or above, your risk of bleeding increases, and therefore the risk of being on warfarin has to be balanced. But in general, the patients with the increased risk of bleeding are the ones at the far end of this initial curve, and therefore, while they have an increased risk of bleeding, have the most to gain from being anticoagulated as well. And it's a nuanced decision, but in general, unless your hazard score is 4, 5, 6, it's really worth trying to get people on anticoagulation. So anticoagulation works. Its benefits persist in the elderly and high risk, and in the fallers as well. A lot of people will have a fall and they get their anticoagulation stopped. You have to fall quite a few times in a year to actually lose the overall benefit of being on anticoagulation, in the order of about 20 or 30 times. Complications increase in the high risk, but the net benefit still favours anticoagulation. And this is just to demonstrate, this is age here, and this is the very young, and this is the benefit purely on age in terms of preventing strokes on anticoagulation. And clearly, the older you are, the bigger benefit you have, because you're more likely to have a stroke, and therefore you're ameliorating a greater risk. So I think we have a simple tool to work out who's at risk of stroke and would benefit from anticoagulation. We have a simple tool for stratifying that treatment, and we have simple medicines that will do that. Warfarin is as cheap as chips. The DOACs are less cheap. They do come with a slightly reduced risk of bleeding, which is advantageous. If you asked me if we had a set pot of money and did I want to make sure everyone who's currently on warfarin was on a DOAC, or everyone who should be on warfarin was, I'd rather spend the money on getting everyone on warfarin, if I'm perfectly honest. But that's a difficult discussion to have. And actually prescribing and following up NOACs is quite simple. You need a full blood count, use a knees once a year and make sure their body weight hasn't dropped too far. The real issue is initiation, I think, and the counselling. We're talking now about locally enhanced services and this happening in the community, which is great. But if you've got to sit someone down and go through the rights and wrongs of anticoagulation, the do's and don'ts, not to eat, broccoli and avoid grapefruit, and be careful if you start feeling, noticing blood in your urine, and not to miss doses if you're on a NOAC, and if you have, you can take it within 6 hours, and do you understand all that? I'm not sure that can probably be done in the 7-minute consultation. And I think, while I do think we need to be moving this into the community and getting it done quickly, I think we have to recognise there has to be a new model to deliver that within practices, possibly within clusters. There'll be a lot of discussion around that, but I think it has to be outside of the normal GP consult, because it's different to the normal GP consult. And the other thing is, nurses do this really well. Management treating symptoms. It doesn't mean cardiovert everybody. It doesn't mean don't cardiovert anybody. It means treat symptoms. And the reason for that is you're trying to make people feel better. There is no evidence that any strategy that tries to maintain your sinus rhythm, rather than just making you feel better, makes you live longer or have less stroke. There's a lot of effort being put into proving this, because there's a lot of people who want to keep people in a normal rhythm, but we haven't demonstrated this. A rate or rhythm control strategy will not influence your outcome in terms of mortality. It might well influence your outcome in terms of morbidity, but that's an empirical journey for each patient. So, given that, what you need to do is just treat symptoms. Any rhythm control strategy for persistent AF will require anticoagulation, even if you've got a CHAS-VAS score of 0, because to bump someone out of AF into sinus rhythm, you need a period of anticoagulation first. It's fairly obvious, but it just needs to be said. So what do you do with, I've no idea why that red line's there. Persistent AF, well, the first thing is you rate control them. You want the heart rate to be somewhere between 70 and 90 beats per minute when they're sitting down, and you want the heart rate to be able to go up to about 120 beats per minute when they run for a bus. And you want that to happen in a gradual manner rather than a very quick step change. And that's often where people get symptoms. It's not how high their heart rate gets up to, it's how quickly it changes. It's that sudden change that people notice. And often why they then describe getting a second wind as they habituate to the rapid rise in heart rate. And that's best done with calcium channel blockers and beta blockers. I use beta blockers first line. Digoxin's fine for sedentary little old ladies and gentlemen who aren't getting up and about much, but it has very little control of the heart rate when you're walking around, so it's not very good for anyone who's getting up and walking around. It can be a reasonable adjunct in addition to these as well, and you can use both of these in conjunction, but also you have to be careful about profound bradycardia when you combine the two. If they are young, you're probably more likely to consider a rhythm control strategy because it just seems right to try and keep them in a normal rhythm, but I couldn't back that up with any evidence. And if you're still symptomatic despite good heart rate control, then you need to first of all do a bit of detective work. Have you actually got good heart rate control? Is the heart rate good at rest? And what's it doing when they actually get up? Actually, are you losing control so they get up and walk around? And therefore, do you need to increase the rhythm, the medication a bit? And then also, are they getting drug intolerances? Beta blockers work very well, but they have a lot of side effects. People feel tired, washed out, they're impotent. And all these things impact on people's perception of how they're feeling, obviously. So you need to think about that, and if so, think about changing from beta blockers to calcium channel blockers or vice versa. And then finally, if you're not doing that, then you do need to think about bailing out a rhythm control strategy, which means a shock in the first place, and then attempts to maintain you in sinus rhythm, which is the same drugs you would use for someone who has paroxysmal atrial fibrillation, who you're giving it to reduce the episodes of atrial fibrillation and reduce the length of time when they occur. And again, the first line is usually class 1 agents such as flecainide, propafenone, disopyramide. Flecainide is pretty much my first choice. You can't use in people with heart failure or ischemic heart disease. Not clear, there's quite a bit of overlap. In those patients, I tend to go for sotalol, which works very well. The trouble with sotalol is it's a beta blocker plus, and if you do have intolerance of beta blockers, you're definitely going to have intolerance of sotalol, and people can feel quite polaxed by it. And you do at least have to do an ECG about a week afterwards to check their ECG so they haven't got a QT prolongation on it. And then amiodarone as a last resort. It's a fantastic drug. It works incredibly well. It treats all sorts of arrhythmias, but it does have side effects. And the longer you're on it, the more likely you are to get those complications, including thyroiditis, hypothyroidism, pulmonary fibrosis, hepatitis, mononeuritis, multiplex, cataracts. The list goes on and on. So I use it in people in heart failure, who I don't have any other options. I use it a lot for my heart failure and ventricular arrhythmia patients, and I use it in short, focused 3 to 6 month bursts in patients who I'm working up for an ablation to obviate the need for this in the future. And the simple fact is the natural history of atrial fibrillation is that you'll become persistent with time. However, most patients will habituate to this, and the cliff edge that they imagine being persistent atrial fibrillation isn't always the case. And you have to have that discussion with them before talking about any further interventions, because they don't come without a cost. There's a risk of stroke and tamponade when we do an ablation. But in people with paroxysmal AF, I think an early review in an EP clinic is advised, because you can at least have that discussion, counselling. Often most people, if they've had 3 or 4 episodes, will say thanks but no thanks, and they leave the clinic, but they have a see on symptoms appointment that when their symptoms become more intolerable to them, or they're finding that they're getting less benefit from the medicines, they then just phone up my section, we put them back in to go from there. And then we start prepping them for an ablation. What is it? Well, this basically is the slide in New England Journal that underlies the last 30 years of efforts in EP work. A guy called Michel Hazaguer, who's the doyen of electrophysiology in Bordeaux, took people with very symptomatic AF, sat them on an EP table, and just waited for them to have little bursts of atrial arrhythmias he'd noticed on monitoring that they kept having before they had AF, and mapped where they were, and they all came from these 4 little clusters which correlate very nicely to the pulmonary veins. And what's happening is these pulmonary veins here, this is a healthy pulmonary vein. This one here, you've lost that kind of sleeve, and you have little muscle strands growing into the vein, and these are autonomous and act as give little bursts of electrical activity that just boom, 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 and will either peter to nothing or drive you into AF. I tell patients it's a bit like pulling a starter cord on an outboard motor. It'll either catch or it won't. And by essentially isolating these, we stop that happening, and it stops driving to AF. So it works very much better for paroxysmal rather than persistent atrial fibrillation. And we create a geometry and just essentially use a heating catheter to draw around these pulmonary veins. So for treating symptoms, there's an increasing stratification of risk and intervention available to you, but it really does depend on symptoms. And the vast majority of our patients are going to be down here completely unaware that they're in atrial fibrillation. they need anticoagulation. They don't need any fancy tests and risky ablations. It's these patients who keep knocking on the door, who keep coming to A&E every time they get an AF, who keep having to take time off work, who are really struggling. And it does tend to be the younger patients because they tend to be more active. They're the ones we need to be thinking about, but we're really talking about the tip of the pyramid here. And at most, I think probably of all the patients in AF, 5% of them are the ones I'll actually end up needing to see and counsel with regards to an ablation. About 20 or 30% I can sort out with medicines. You know, of that 5%, probably only half will then agree to go ahead and have it done. So, what do our patients deserve? I think they need an early diagnosis when symptomatic. They might deserve screening for asymptomatic episodes, especially if we can square that circle about how we can actually get that information seamlessly without too much resource utilization and ability to manage the data. They certainly need risk stratification with regards to oral anticoagulation. They then need initial medical therapy for symptom control, which can be done fairly simply with beta blockers and calcium channel blockers. And those who continue to be symptomatic or perhaps young need a review in a specialist clinic to assess the response to that treatment and whether any further escalation continues. So where is this best done? And does a 7-minute consultation offer sufficient time? Questions?
James, that was really interesting. Thank you. We've actually got 10 minutes for questions for yourself, and then we'll have some general questions to our 3 panellists who I'll invite back to the stage, if that's okay. So I'm going to kick off in North Wales this time, so keep kicking off here. North Wales, have you got any questions for James?
Yes, we do. Just getting the microphone to Dr. Flannery, GP in Towyn.
Hi, Mike Flannery. A little bit of feedback there. When a GP, I just going to ask, what would your sort of first choice calcium channel blocker be? Or
Okay. In general, I use diltiazem because I can remember the prescription dose. Verapamil would be the other option. Amlodipine doesn't have a role to, or the non-dihydropyridines don't have a role to play because they don't have any effect on the AV node.
So the question there was, which calcium channel blocker would be the first choice for rate control in atrial fibrillation?
Can you hear me? Because I thought I just answered it. But
okay, we can hear you now.
Okay,
say
sorry.
it again, please.
Diltiazem is the one I use, but diltiazem or verapamil, and preferably a longer-acting prescription because it's more convenient. I don't use the non-dihydropyridines because they don't work on the AV nodes. Amlodipine, felodipine, nifedipine, they're not much COP.
Thank you. We got that second time round.
Okay.
Is there another question from North Wales? Then I'll switch to here. Any more questions?
Our understanding of screening for atrial fibrillation is you need to benefit from that. So your CHA2DS2-VASc score should be 2 or 3, depending on your take of risk. Even if you're asymptomatic, you need to get some sort of benefit through anticoagulation. Does that make sense?
Oh, yes, absolutely. And the trial I just described, we took people who were at least CHA2DS2-VASc or above.
Thanks very much. Right, have I got any questions here?
It's just a couple of comments, really. I thought it was a fantastic talk, and it shows the importance of having alignment between the hospital specialists and the general practice constituency, because having the same message coming out and the same kind of targets and priorities, I think, is very powerful. And I think if we could clone people like yourself, and I showed that guy Taz Chowdhury, the diabetologist, in community clinics and MDTs, it's a very powerful message, I think, kind of using that resource. But again, it does require, people having some programmed activities, to be able to take you out. Otherwise, you've got no capacity to do that, just as we do. So that's one point, alignment. The other is the other stakeholders here are pharmacists. And they're using pharmacists in a number of centres to identify people who in GP practices come into your practice and kind of identifying those who are on aspirin monotherapy and then kind of doing a virtual clinic looking at the electronic record and then making a recommendation. That's quite an efficient use. It's been very successful. And then lastly, other risk factors, statins in people with AF. I know it doesn't reduce AF, but it reduces their incidence of MI and the question of blood pressure control. So maybe you could say something about those couple of things.
Sure. So I think a couple of things. You're right. It does take people breaking down the barriers. It's how we do it. You're right, and resource is always an issue. So my waiting time for a procedure at the moment is about a year. I'm one of 4 electrophysiologists in Wales for 3 million people. So we struggle to get out of the hospital. I think the way we've done it, which has worked very successfully, and Rav's sitting here now at the moment, is, and I speak specifically for ABMU, I appreciate this is an all Wales meeting, is that we've created some GP with specialist interest roles. We now have 5, if I remember correctly, based around our group, and they act as a sort of conduit for referrals, triaging, advice, and we email regularly, and I think that works very well. And there's some way of sort of trying to align almost sort of a filtering process. In terms of risk management, as I said, it's a very common bedfellow AF with ischemic heart disease, hypertension, and all these other things. And certainly, and there's some very good work from Prash Sanders in Adelaide, where he's actually taken people with AF and he's just aggressively managed those risk factors. And what he's shown is not only is the outcomes better in terms of stroke, but so is the symptom outcome, to the point that they have less AF, and when they have AF, their symptom scores are much reduced, dramatically so. And this is, and when you actually sit down with them with a beer at a conference and ask him, well, what exactly are you doing? What he says is, well, we get them to go on a blood pressure monitor and we tell them they're fat and they need to lose weight. And that pretty much does it. If we can do that and get people to stop bloody smoking, I think, we'd all have a lot less jobs to do. And then finally, I've forgotten the third point, sorry. Pharmacists, I think that's a very good point. And again, in Wales, we had a period when we changed QOF scores, recognising that aspirin had no role to play after the changing guidelines. There was an audit of all these things and people moved over, which created a bit of a problem in the anticoagulation clinics, but it was ultimately absorbed with extra resource. So we do have pharmacists who are interested, and again, in ABMU, we have a very active pharmacist who's particularly interested in screening and is currently doing a PhD, and he works a lot with Jules Halcox, my colleague, who does a lot of work in prevention. But Jules has worked a lot and has got a few grants in West Wales looking at using pharmacists and opportunistic interactions. And I think pharmacists, nurse practitioners, these are very valuable people who we can use to help drive a lot of is actually fairly simple medicine.
We have got workshops with pharmacists who are involved in this kind of work this afternoon. There's still a few spaces on that. So, any more questions?
Sorry, just a quick question.
One more.
Warfarin DOAC, because in practice we do start DOACs, and we're much more likely to start a DOAC than go down the warfarin route.
I'm not a zealot for warfarin or DOACs. I'm a zealot for oral anticoagulation. That's what I was trying to get across. I think DOACs work. I think they're very good. I think they're very useful, and I think they're very easy to initiate in terms of you don't have that loading period, which in a clinic, a GP clinic, where you've got to see all those people knocking on your door to bring people back to have more and more blood tests isn't very helpful. I realise that. They do also reduce your risk of bleeding, specifically intracerebral bleeding, it would seem, and that's obviously a very potent attraction to patients. And I think in 5 years' time, I won't be mentioning warfarin. I think that's the natural change of things. I just didn't want everyone to feel that we had to be switching people over at this stage. Is that fair?
Yeah, I mean, it's just, the warfarin issue is, I thought was settled. Most of us now have got in our minds that we are, apart from the mitral, I think there's an issue with mitral.
Well, so non-valvular AF, that's the other thing we should say. So people with prosthetic valves and significant mitral stenosis should still be on warfarin, yeah.
We've got another
two questions in North Wales.
Yep.
I'm a practice nurse up here in North Wales. Once you've made a diagnosis of atrial fibrillation, how soon after the diagnosis would you suggest that we should be starting anticoagulation, knowing how busy we could be on a Friday afternoon and you've made that diagnosis? Thank you.
I mean, I think the honest answer is as soon as possible, but I don't think we're expecting you to admit someone or give them Clexane over the weekend while they await counselling. I think if you can reliably see someone, initiate counselling, get a set of bloods and make sure it's the right thing to do within 2 to 3 weeks, I think everyone will be very comfortable with that. But the sooner the better.
Our iceberg picture in palpitations in primary care is the ice above the sea is atrial fibrillation, but the giant iceberg below the water is benign palpitations. We're using more of the event monitors to try and differentiate the two. Are you comfortable with us just relying on the software reports of the current ambulatory event monitors?
In general, they're very reliable, so yes, I think that's fine. I think the majority of them would pick up AF or anything else you need to know about, and they do tag very well. In general, we're very fortunate that we have that underwritten by physiologists who's screening these event monitors and will just look at events and look for artifacts and things, and that's where you can get into a bit of trouble sometimes, and that you get a bit of dropout, which suddenly gets called polymorphic VT or something, but yes, I think that'd be fine.
Sorry, I think Graham's stolen part of my question there from North Wales, but I was going to ask you, actually, palpitations are a significant issue for us in general practice, and pulling out the wheat from the chaff. And alive core monitors do seem to be inherently attractive. You mentioned that you have a number. This is something we could invest in primary care quite easily, and we could use these to pick out the patients we need to. Do you use protocols? How long do you give them to patients for? Do they run away with them and sell them on eBay? Because they're about 20 quid more expensive on eBay. I've just looked now. So,
well, we got them all back, which is good. They do work, and we haven't written a formalised protocol yet, and that's something that I'm conscious I promised I'd do for RAV on several occasions. What we do have is a rough idea, and I think what you're looking at when you see palpitations are the red flags. You know, the person who's got known to have ischemic heart disease or heart failure, we worry about them more. The person who's blacking out, obviously, the person who's getting chest pain with it, when it's exercise induced, or where there's a family history of people dropping dead under the age of 45. They're the ones that clearly you need to be worried about. For most of them, and then I think, and even then they still need monitoring, and I think the Alive course still offers a lot of opportunity. I think then what we should be doing in general, I think if you've got no red flags, I think an ECG that looks normal is very reassuring as well, of course, and then once you do that, then I think it's perfectly reasonable to send them off to the Alive core, and if it comes back, these are my symptoms, and you look and they're getting ectopics, stop there. If the ECG isn't normal or they have red flags, then I think still send them off with a monitor because you're getting data, but I think then an early review is necessary. But I think it'll really change things, yeah.
Thanks very much. I think it would be great now if we could get all the first three panellists back onto the stage and see if we've got any general questions that link in both with the community and secondary care approach that we've seen with Dr. Robson and with support from Jane. Okay, have we got any questions? Right, go. And North Wales, you can start thinking of a question too if you've got some.
My name is Dr. Potter, I'm a GP. I was particularly interested in your talk, Dr. Robson. Where do you start? We've got isolated GPs with unconnected systems. I just wondered where you would start with that.
Well, I would start with atrial fibrillation, I have to say. You can't get a bigger impact, and you can't get 70% reduction in events. We don't have almost any other kind of long-term condition in routine care that we have that degree of reduction. Statins, 20-25%, blood pressure, 20-25%, very important, bigger target groups, but, this is kind of a no-brainer. And we know that, we've got, almost certainly you've got 20% of people, I would think, still on aspirin monotherapy in Wales. And you could change that within 2 years. You could eradicate that as an issue and so on, and get up to more than 90% of people anticoagulated with AF. I mean, there'll be some that are not suitable, but it's a very small proportion. And so that's where I would begin. I kind of think that's the obvious sort of thing. Yeah.
How do you start the collaboration between the practices and the CCGs, and just how do you get that going?
Well, I think first of all you would get on your side, people like the electrophysiologists and the hospital consultants, and say, let's have a stakeholder group. Who's in the group? Where's the opposition? So we found in my area that some time back the main opposition was from the prescribing advisors. They said, we don't want to go down this NOAC thing. They dug their feet in. They really made it very difficult for us. And then that began to shift. So having them in the room, your main kind of opposition group, if you like, and a discussion with them was a key to making this whole thing move. And it has moved, and they have agreed. And so, getting your stakeholder group, I think, for me, is the key thing. I think having a pharmacist in the room, I think they can very rapidly, go through your records and identify people on aspirin and make you a recommendation. So you're doing a lot of the work for you. And then they can say, well, look, this person is not the first person to choose. They've got dementia, they're dying, they've got, alcohol problems. But here's a 67-year-old woman who's got a CHAS-VAS score of 4. She's on aspirin. Why don't you call her in and have that conversation with her tomorrow? So it's that kind of thing that they can do. So I think having a stakeholder group, having a program, having a target. Where are you at the moment? You've got nationally, we've got this data in your QOF. What proportion of your patients. I would say just forget about the exceptions, because that's about your payment. But without any exceptions, where are you? You're probably at about 70%. So you can say, well, you've got 30% here to gain. And I think it's having, looking at that variability. And if you're a practice, at 65% or even lower, you might recognize that that's an area that you can improve. So I think use the data, have a local target. That target you can set yourselves and say, and then say to the CCG, well, if we get an extra, whatever percentage it is, can you give us an extra resource to do that? And it may be just that they say, well, we'll give you a pharmacist, and or they'll, you get some extra resource as well. So I think it's having a sort of small business plan, about how you do that. But it's that kind of conversation to begin with those local stakeholders. That's the key thing. Just get it right. Otherwise, you'll find that somebody will block it. And I think having the CCG on board, the prescribing advisors, the consultant cardiologists, the GPs, you have to have the GPs on board. Our area won't. Is making it very difficult for us to discuss initiation in the community. The CCG would quite like it because they think it's a cheaper alternative. The GP is saying, well, actually, the hospitals are now doing okay. They're already doing it. Why should we do their workload? Are you expecting? And so on. So perhaps the argument for them there is, well, the worst of all cases for anticoagulation is that you identify these people, you work them up, you prescribe for them, and then at the end, most studies show that at the end of a year, only about 30% of people are still taking their medication as prescribed. So the worst scenario is that these people have been given the prescription and they're not taking it. So my worry a little bit about the NOACs is that, if you've got warfarin, you're seeing somebody every 6 to 8 weeks. She says, how are you? How are you doing? If you don't come, she'll pursue you, and so on. And I think we might want to kind of look at that scenario about how we improve adherence for people, particularly on NOACs, and I think that's another kind of stage, but it may be something that, again, fitting them into kind of the clinics that you already run for warfarin, if you run them in the community, and see people actually every, to begin with, 2 or 3 times a year, and then if they're adherent, not so often, and working on how we can improve adherence, because I think it's quite an issue.
Thank you. Graham, have we got any questions from you? Oh, sorry.
I agree with everything you said, and there's just a couple of points I thought might be worth mentioning. There's a very good service run by the stroke and haematologist in UHW called Stop a Stroke. It's been rebranded now, so it's an all Wales name. I can't remember what it is, but can you remember, Tracy? Oh, okay, fine. Well, but I think that they've done a lot of good work about how we get through into those exemptions, and it's worked very well. And I've done a lot of work on this in our area, and one of the big problems we had was there wasn't a locally enhanced service for Swansea, whereas there was pretty much for everyone in Wales. That's a barrier that we've managed to break down. And then I think looking at it going further forward, I agree with what you say. We need some sort of ongoing contact with them, and I think we need multidisciplinary involvement. And if I was to design it, I would say that we should probably align in clusters, which we already are, and have a GP whose session to be there perhaps a day a week in their timetable with a nurse practitioner and a pharmacist, and that person will be the point of contact for the other GPs. They will develop an experience, be very confident in managing these patients, and have the impact of the counselling and drug management and chronic disease management that these other people can offer as well. And I think moving forward, that feels like a good system to offer that will give us a lot of value, and I think help a lot as well.
Thank you. I think as a network you are in a unique position in that potentially you could try and get some of these things standardised across Wales. Instead of having local enhanced services for different things like NOACs, you could potentially get a Welsh enhanced service and ensure that it was the same, because patients move. They live in different areas, sometimes from the GPs, and that causes confusion along borders. I daren't mention England, sorry. That's a bigger problem where practices straddle England and Wales. But you'd be in a good position, and I think you need to start with what the GPs think that they can do. There was a mention that that nurses are very good at discussing the anticoagulants with the patients, but I don't think our practice nurses necessarily have the confidence on the whole to do that. So actually enabling and training and helping our nurses to talk about NOACs, which they probably aren't doing. They've been doing lots of warfarin bloods for years and years and years, and maybe even doing, some of them are doing the warfarin monitoring, is a step forward, because actually if you're not sticking needles in everybody all of the time, you've got more time to talk to them, but you need to enable that time to be used for the talking about the NOACs, if that's the way you're going.
I'd agree. I think it's good evidence that we do need an enhanced service to enable the training and the monitoring and the patient contact. Yeah.
Just a word of caution about the All Wales service. The people do move areas, but the areas are very different, and in general the models don't tend to work. And we tried to have these discussions previously. The message we got back was it won't work here, and I think there needs to be some sort of ground representation and sort of local innovation, as opposed to a sort of one-size-fits-all strategy.
We are geographically challenged in Wales. Having been at a festival in North Wales, and my daughter was at a festival in Dorset, and she popped her knee out at 3 a.m. and having to drive down there. It's geographically very moving around can be quite challenging. Have we got a North Wales perspective on that?
Thank you. My name is Uttam Chauhan, pharmacist. Our keynote speaker touched on a very important thing, is to use the technology that we have. And in the GP land, there's quite a lot of information out there that we could analyze. There's so much information about the use of aspirins or no treatment in AF or blood pressure control, unlike in the secondary care. Secondary care is lacking in this IT technology. But having worked in the primary care for a very short period of time, I think there is so much scope to bring the data together and having the ability to analyze it and then taking it forward with the GP clusters to see whether we can make some progress into any kind of intervention that you want to make. So I think the data set is there, but we need the means to bring that together and a leadership to take that forward as well.
So Uttam spent a year looking at anticoagulation in primary care and has changed some patients from aspirin to various anticoagulants. I think he's found it's been difficult to improve on GP care in that respect, but has done a lot of work in identifying patients with poor time in therapeutic range, poor TTRs, below 50% in many cases, who need a different anticoagulant in order for us to do good, not harm as we are currently. So we'll flag that, really, looking at using IT in primary care to quickly identify, within a few seconds, patients whose time and therapeutic range, TTR from the diagnostic software, certainly below 50%, below 60 or 65%, they're going to be getting little, if any, benefit from their warfarin.
Thank you. Well, we're 5 minutes to 11. I'm going to suggest now one more question, and then we're going to break for coffee. Okay?
Hello, I'm a GP in Aberaeron. I think what we're learning is that this is everybody's problem. And I don't think that any of us can take on the huge burden alone. And I'm just wondering where Public Health Wales fits into this and public raising awareness. I think our patients are very aware that they need to get their blood pressure checked, but not necessarily their pulse.
You're right, there does need to be more patient information. The Arrhythmia Alliance in particular has a lot of successful campaigns. Now, it's certainly very well documented in England. It does happen over here as well, and there's usually some BBC comments when they have a Know Your Pulse week where pharmacists will stand in supermarkets, or nurse practitioners will, and generally encourage people. And they do have, I forget the numbers now, but I think last time it was something about 10,000 extra contacts and pulse checks during that week as a means of trying to increase familiarity. And there is that work available, and I think that will continue, and that's probably what we need to build on, rather than allowing Public Health Wales to reinvent the wheel.
Yeah, there are a couple of things. So one is that there's just been an HTA report on pulse screening that's come out positively, saying this is a cost-effective way of progressing. So I think that although the National Screening Committee at the moment doesn't support it nationally, I suspect that their view may have to change now. That's the first thing. In East London, we have incorporated pulse checks as part of the NHS Health Check. In fact, doing a pulse check is actually mandated under NICE guidance as part of your blood pressure measurement. You should initially check this patient doesn't have atrial fibrillation. So, in a sense, you're carrying out proper NICE guidance of blood pressure measurement by doing this. So, you've got the nice sort of stamp that, what you're doing is okay and that you could incorporate this. But incorporating it means you just... it's easy to say that, but to make it easy to do in general practice, you need to stick it on all the templates, so that if you've got a template for data entry, for pulse checks, for NHS health check, it needs to go on that, new patient checks and so on. So it just makes it easy to do, and I think you very rapidly see, that rising. So I think that there is a kind of role, as it were, for public health. But I think the other, question is still, why are we stuck with these QOF targets of 150 for systolic blood pressure, when all guidance says 140. I don't understand it. You get this huge, gain from, this further, 10 millimeters reduction. And it's just, again, it's a sort of a quick win, I think.
About the pulse screening you were discussing a few years ago at this meeting, there was a discussion about blood pressure monitors because of the 5-year. We invested for all our nurses in obviously Omega monitors with the kind of AF modules. So all our nurses, when they do blood pressure, all the patients get an AF module. So it's actually done automatically as part. So what's your experience using that in your, is it effective having these blood pressure cuffs with AF modules? Should we be investing in getting all our, blood pressure cuffs like that?
Okay, so different practices have done it different ways. Some have just done a simple manual pulse check. In East London, we've do you have healthcare assistants at all? Yeah. So our healthcare assistants are running, the NHS health checks, and so they're not clinically trained, and so they might need training to kind of test the pulses. So for them, these, an Omron that will do, kind of pulse regularity, is a very simple way. But as pointed out, only about 1 in 10 of those irregular pulses, will turn out to be AF. So one of the things that our CCG has said is, oh my gosh, we're spending all this more money on ECGs now. Can't we reduce that? So one of the issues is, they have quite a high, negative predictive value. So if you don't have an irregular pulse, you can be reasonably confident that they don't have AF, although, there is this issue that if you're symptomatic, you do need to come back and see me again, kind of thing, because it might be intermittent. But so it's whether or not these devices, like an AliveCore, and even if we speak, we're about to roll out alive calls across North Central and East London as part of the national innovation kind of scheme. I've just been shown another device where you just put your finger over the iPhone camera, and it will give you, with a high degree of sensitivity and specificity, that same thing. So I don't know how soon these alive core machines will be kind of, sort of the latest technology. But anyway, so they seem to be quite useful, though, and in terms of, ruling out AF. Do you want to? Is that?
I think so. I mean, there are two issues, aren't there? There's how do you reliably capture it and how you do it in a way that's quite convenient and doesn't require a lot of reviewing. And I think there are a lot of devices coming out with this, including essentially it's almost like plethysmography. It uses the flash from your phone to actually measure your pulse and look for irregularity. And that's a very good screening tool. Of course, doesn't document the rhythm, which is the next part, and that's where the alive core had that advantage. A live core, though, you have to hold it between your hands, you have to make an active decision to make the recording. And of course, you've got symptoms, that's fine, but if you're getting very fleeting symptoms, it's not so good, and of course, you're blacking out, it's no use whatsoever. So the next thing is then how do we move from something that you can wear that will do that and actually give you meaningful, accessible data, not too much. A reassuring pulse check is good at the time, but as we said, there is that iceberg underneath. Interesting, when we screened for this study, we did find, I can't remember the exact numbers now, but I think 7 or 8 patients who were in persistent atrial fibrillation weren't aware of it when they came to us. And these were people who were having their blood pressure checked and everything else. But there is undoubtedly a cohort of people who will progress to persistent AF, but at the moment are paroxysmal and perhaps asymptomatic, and that's what we found in the study. So I think as a screening tool, I think anything that gives you a rough, broad brush, yes, no, I think is an effective way of picking out the more likely candidates, but you will undoubtedly miss some, and that's where we need to then think about advanced screening beyond that.
I'm going to have to draw it to a close in a minute.
Okay, just one point. So Richard Hobbs, in his SAFE study of opportunistic testing for AF, increased his register size by between 5 and 10%. We've been looked at our routine data in East London. We're just about to publish it. We've increased it between 3 and 5%, that kind of order. So, substantial numbers.
Thank you so much to all of our speakers this morning. And we've got some technology stands and lots of other rep stands for you to go and have a look at while you have your coffee and biscuits. And can I get everyone here at 25 past, please? Thank you.
Still very well. I didn't know there was
if you want to do it at lunchtime, get the laptop with the 4 presentations. Just make sure they're all linked up into the same file. So
yeah, do it at lunch because I'll have to.
Perfect.
That's to go. Yeah.
That's fab.